welcome to the American Journal of Psychiatry Residence Journal podcast series. My name is Matthew Edwards, and I'm a third-year resident in the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine, and Senior Deputy Editor of the American Journal of Psychiatry Residence Journal. I am honored today to be joined by Dr. Anna Lembke, Associate Professor of Psychiatry, the Director of the Stanford Addiction Medicine Fellowship, and the Chief of the Stanford Addiction Medicine Dual Diagnosis Clinic. Dr. Lembke received her undergraduate degree in humanities from Yale University and completed her medical degree and clinical training at Stanford. Dr. Lembke is a well-regarded expert in psychiatry and addiction medicine and the author of the widely influential book, Drug Dealer MD. Dr. Lembke's account was one of the first accounts in the medical community to deal head-on with the opiate epidemic and opiate overprescribing. Dr. Lembke has testified before Congress on the opiate epidemic and is a frequent guest of major media outlets discussing the implications of the opiate epidemic for patients and healthcare providers. Dr. Lembke, thank you for taking the time to speak with me today.
Well, I'm so happy to be here. Thanks for inviting me.
Oh, absolutely. The pleasure is mine. Dr. Lembke, in Drug Dealer MD, you discuss your career path and how you became interested in addiction medicine. For our listeners who might be unfamiliar, would you be willing to discuss some of the factors that led you to a career in addiction medicine?
Well, I trained in the 1990s and started my residency in psychiatry in the early aughts. And one thing I was certain I was not going to do was to treat people with addiction. And that comes from a couple of different factors. I really didn't get any training in medical school or even in my psychiatry residency about how to treat people with substance use problems. I had a family history of addiction, and so I think there was some countertransference for me toward people with addiction. And so I remember when I was starting in the mood disorders clinic, I had done a fellowship in mood disorders, so that was kind of my career path. I told the intake coordinators that I would see anybody, as long as they didn't have a substance use problem. And shortly thereafter, they informed me that there were very few patients who actually met those qualifications. It was funny, and early on there was kind of like a don't ask, don't tell policy with patients, which I think is still prevalent. But when I started to ask my patients about substance use problems, it was amazing how eager they were to talk about them. And it opened up this whole world for me that I really had been ignoring to my patients' detriment. And so I learned a lot about addiction primarily from my patients.
Your career in addiction medicine grew out of, it seems, at the beginning, a reluctance to treat these patients.
Yeah, for sure. And, what was really interesting was once I started paying attention to addiction, asking patients about addiction, trying to intervene with that problem, I discovered two things. Number one, I discovered that addiction gets better, and it's really, really exciting when it does, because not only does it improve the life of that individual patient, but there are so many concentric circles of impact to family members, friends, whose lives get better when someone gets into recovery. The other thing I discovered is that I really like patients with addiction. I do have this bias that I think they're kind of above average intelligent. A lot of the time, they're super creative. They've got incredible tenacity, sometimes for the wrong things, but they're a really, really interesting cohort of people. And so now I wouldn't want to do anything else.
Your book discusses both the opiate epidemic as well as the often comorbid or crossover addictions that many people face today. Can you tell us a little bit about the opiate epidemic we face today? When was it first recognized, and are we at a better place now than in the early 2000s?
I really think the turning point was 2011 when the CDC came out with a public health announcement just saying, roughly quoting, we are in the midst of a drug overdose epidemic, the cause of which is overprescribing of opioids and psychotropic medication. To me, that was a really powerful statement because it didn't just acknowledge the rise in drug overdoses in this country, it acknowledged the cause, right? Overprescribing of opioids and psychotropics. And the and psychotropics part is often forgotten or left behind, but our benzos, our antidepressants, our stimulants, gabapentin, those are the drugs that we're finding, in people who overdose. And to me, that was a really important moment. It was a turning point because it sort of said, hey guys, we have ignored this for far too long. How long had we been ignoring it? Well, really, it started in the 80s when there was this paradigm shift toward treating pain with more opioids. That was also kind of an adjunct to the hospice movement, using more opioids at the end of life. But that morphed, in the 90s to using opioids for minor and chronic pain conditions. And it just basically escalated from there. When you look at opioid overdoses are really just one metric, but they're the most obvious metric by which to measure this epidemic. You see those opioid overdoses started to escalate really in the early 90s, and it was really, at the turn of the century, the early aughts, when it just took off. And now we're experiencing, more than 130 opioid-related overdoses daily. What started out primarily as a prescription opioid overdose epidemic has now morphed into a primarily heroin and illicit fentanyl overdose epidemic. So I would say that's the general trajectory.
I see. You've mentioned in earlier writings and media that there were sort of three factors that kind of helped explain the current crisis. I remember two of them, one being illness narratives, one being the sort of medicalization of mental health and addictions. Do you mind speaking a little bit about those?
Sure. So what I talk about is all the invisible forces inside of medicine that incentivize and promote overprescribing. One of the obvious invisible forces is the role of big pharma that works kind of like an invisible hand in the background, influencing professional medical societies, the very watchdog organizations like the Joint Commission, the FDA, the Federation of State Medical Boards, intended to ensure safe practices. I mean, really, Purdue Pharma and others have done an absolutely masterful job infiltrating those organizations to convince doctors that opioid prescribing for minor and chronic pain is founded in science. In fact, there is no science to support their use for those indications. So that's one of the invisible factors. It's the way we're in bed with pharma. Another important invisible factor is what I've called the Toyotization of medicine. And what I mean by that is this mass migration beginning in the 1980s out of physician-owned practice into large integrated healthcare centers. So today, over 70% of physicians are salaried employees for major hospital corporations. As a result, we have certain pressures on us that existed before, but now are turbocharged. Those pressure, I've called that the P paradigm because I tend to remember things if I make up some acronym or something or an alliteration for them. But basically, there's enormous pressure on doctors to perform procedures and prescribe pills because that's what gets reimbursed. To please patients because patients have essentially become our customers, and also to palliate pain. This paradigm shift around pain in the Joint Commission with pain as the fifth vital sign. We also, practice more and more protocolized medicine with a kind of a top-down approach. So docs have lost a lot of their autonomy, right? We have to apply this protocol and we have to, meet this quality measure. And so it's really changed the landscape for how physicians practice. And I think that's been a major factor in influencing and incentivizing opioid overprescribing. The third factor is something I call the medicalization of poverty, and that's a lot to go into. I detail in my book, but basically what I'm saying there is that increasingly in the last 30 years, doctors are asked to care not just for their patients' biomedical problems, but also their complex psychosocial and socioeconomic problems. But we're not actually given the tools to do that. So instead, we medicalize problems like homelessness and multi-generational trauma that are not in fact medical, and then we prescribe a pill for it. And there's evidence to show, for example, that Medicaid patients are twice as likely to be prescribed an opioid for pain and 6 times as likely to die of that opioid. Really huge socioeconomic differentials. There are data showing the astronomically and unacceptably high rates of opioid prescribing to pregnant women on Medicaid, which are not comparable to the lower rates of prescribing in non-Medicaid patients, who are pregnant. So this kind of thing. And then finally, the cultural force that I talk about, the invisible force that I talk about that's, I think, important to this is a cultural factor having to do with how we conceptualize pain. And today in medicine and in society, we really think that pain is dangerous. That if our patients are in pain, not only are we failing them morally and medically, but we're also setting them up for future pain in the form of something like post-traumatic stress disorder or a centralizing pain syndrome. So we have this idea that pain actually damages the brain and leaves a kind of psychic scar. Now that's very different from how medicine used to conceptualize pain 100, 150 years ago and prior, when people actually believed that enduring pain and getting through to the other side made people more resilient. This idea, what doesn't kill you, Nietzsche's famous quote, what doesn't kill you makes you stronger. But there really was this idea that enduring pain was salutary. One of the sort of small, historical facts that I find fascinating is that when general anesthesia was first introduced, I think in the 1800s, mid 1800s, most of the leading surgeons in the United States didn't want to adopt it. They felt that it was good for their patients to endure pain during surgery, that it would boost the immune response, that it would, boost the cardiovascular response. Like that now seems barbaric to us, but that really was the thinking. Ironically, what we're seeing now is that in fact, using opioids perioperatively probably does suppress the immune response and probably does retard healing. So to me, these kind of historical shifts, cultural, socioeconomic, the way that medicine is practiced, the healthcare delivery system, the role of big pharma, those are all really fascinating and really important to grasp in order to understand what drives the incredibly persistent problem of overprescribing that we still face today.
Thank you for such a nuanced...
You're welcome. You're so positive. Thank you.
And I think about, as I listen to what you're saying, I think about all of these factors, these invisible forces, are all complex in and of themselves, which helps explain the difficulty in addressing the opiate epidemic and the other issues with addictions that we have today. You mentioned history, and I've taken quite a liking to history.
Yeah.
Historically, there are a number of significant events in the history of pain assessment, and pain treatment. Frankly, this is not our first opiate epidemic. As you discuss in your book, an epidemic in the 1900s when heroin or diacetylated morphine was marketed alongside Bayer aspirin, followed by a heroin epidemic coinciding with the Vietnam War. That actually subsided when many of those folks came back home, are two of the clear periods of opiate addiction in history. The introduction of early opiates, promising to cure any pain ailment like laudanum, and these early epidemics, many of which led to the Harrison Narcotic Act of 1914, which among other challenges and changes stipulated licensing requirements to prescribe these medicines and instituted penalties for doctors who were thought to be, inappropriately prescribing the medications. So we've also seen these sort of shifting demographics of the individuals most associated with addictions over time. I think Keith Wailoo, in his book Pain: A Political History, talks about Rush Limbaugh as one of the notable figures during the sort of OxyContin era. The Victorian era was notably one in which a lot of sort of well-to-do women were over-medicated or accused of being over-medicated by their physicians. And in the sort of mid-1900s, the shift to, sort of lower socioeconomic classes has dominated. And even now we see another sort of demographic shift. So the role of history in sort of understanding and explaining and even sort of conceptualizing our current addiction, I think plays some role. Have these histories informed our current epidemic or understanding of it? And what lessons can we take from history going forward?
Right. So I think the most important lesson we can take from history is that one of the biggest risk factors for addiction on a public health scale is sheer access to the drug. When access goes up, addiction goes up. And we see that again and again. There are so many historical examples of that. You gave the early 1900s. Again, it was available over the counter. Heroin was based on the German term heroisch, which was supposed to be this non-addictive form of morphine, so much safer. You can give it to babies. And of course, we had legions of people get addicted. Then the Harrison Narcotic Act essentially made it illegal to provide opioid in any form to patients, except for patients and extremists. What the Harrison Narcotic Act really did, though, was it said, docs can't provide opioid to opioid addicted people. So it was interesting. If you go back, there are reports of doctors already trying to do MAT, basically trying to do like a methadone maintenance program before methadone for these folks. And that's what the medical community and the broader community really went into uproar about. And that's, I think, what really spurred the Harrison Narcotic Act, which was a taxation act, but basically de facto made it illegal to prescribe opioids to people with opioid addiction. So access went down and opioid use went down and opioid addiction went down. As you cite, the Vietnam War era, access went up. When our soldiers were in Vietnam near the Golden Triangle, they had access to opium. They got addicted there. They came back, their access went down. They stopped using, except for a smaller subset of severely addicted people. What we have with this opioid epidemic, though, is access on an unprecedented scale, leading to an unprecedented number of addiction and death cases. But also really important is that this was the first time that opioids were being aggressively prescribed for the treatment of pain long-term at extraordinarily high doses with extraordinarily potent delivery mechanisms, intrathecal pumps, submucosal, transmucosal, absorbable formulations, lollipops that people, were sucking 24/7. I mean, you've probably seen those patients. So it really was the combination, again, of the pharmaceutical industry, this misrepresentation of the science, and the whole shift in the paradigm of treatment of pain that caused this what we have today, which is an opioid crisis, which really rivals any opioid crisis probably in the history of the world, including, the opium wars, for example, in China, which was also a very significant opioid crisis. You ask about demographics. That's very fascinating. When a drug epidemic afflicts a certain population, and then how the community interprets or responds to that. One of the major criticisms of the opioid epidemic is the way that because it affected white, middle class, insured patients, all of a sudden opioid addiction became a disease, versus like the crack cocaine epidemic in the 1990s that mainly afflicted Black Americans living in the inner city. Then it was like a moral turpitude problem, right? So and that's really very legitimate criticism that plays out in interesting and different ways in different societies. So one of the interesting corollaries to me is, for example, in China, they have pushed really hard to get video game addiction to be recognized by the World Health Organization as a bona fide addiction. Now, why would that be? Because a lot of the rich, wealthy Politburo's kids are addicted to video games. So when their kids are addicted to video games, it must be a disease. But there are a whole lot of people in China addicted to heroin who are treated basically like criminals. So these sorts of things, these patterns. I mean, you're a historian yourself. I go to you for when I have history questions, and you're very aware of these kind of recurring themes, but also the ways in which a new manifestation of this phenomenon can take on very different aspects at a different period of time. And I think, what's salient and important, again, about the current opioid epidemic is just the sheer scale of it and the way that doctors really were and continue to be a major conduit, plus all the potent formulations, the variety, the potency, the delivery mechanisms, the huge, pharmaceutical machinery that rolls these things out so that a small town in rural West Virginia, is suddenly flooded with pills. So this kind of transportation revolution.
Thank you so much.
You're welcome.
Your early role in sort of signaling out the hazards of opioid overprescribing, physicians' sort of good intentions gone awry, and the shortcomings of doctors, professional medical societies, regulatory agencies, and pharmaceutical companies reminds me of another event in the history of medicine. As you know, Dr. Henry Knowles Beecher was a Harvard anesthesiologist and pain researcher who promoted the idea that pain was not entirely biologic, but largely driven by a reaction component, which was a term he developed for the cognitive, affective, and social aspects that shape a person's experience of and response to pain. His lasting contribution to pain medicine was that pain was different for each individual, which he arrived at by a sort of ingenious sort of crossover double-blind study of medications, which was spurred or inspired largely by his sort of clinical acumen, in which he observed the narcotic requirements of soldiers that he had treated in World War II compared to his later experiences treating civilian patients at Massachusetts General Hospital. And he found that, by and large, the patients that he treated at Massachusetts General with less severe injury needed more narcotic relief. At the time, he coined or attributed much of this to the sort of coming home of soldiers who would be rewarded with medals and the sort of admiration of the community, versus the opposite transition of the civilian patient to, the unknown territory and unfamiliar environment of the hospital. So Beecher has this quite important role in the history of pain, but he's perhaps better known for his 1966 expose in the New England Journal of Medicine titled Ethics in Clinical Research. And in that paper, which led him to be characterized as a whistleblower, he called to attention lapses and the ethical conduct of research, a move that was sharply criticized by others and widely unpopular. Nonetheless, his paper laid the ethical foundations that we continue to use in clinical research and contributed to the development of the IRB. And so, like much of the work we do around pain and opiate overprescribing, though initially unpopular, this type of work leads to safeguards from which we benefit and help take care of patients today. In what ways has your work in discussing the hazards of overprescribing impacted your career, either positively or negatively?
Yeah, so, I think for the most part, it's been very positive. It kind of, when I wrote the book, Drug Dealer MD, I really didn't expect but maybe a handful of people to have any interest in reading it. I was really shocked at the reception, and in a funny kind of way, it was also really stressful because, when you're privately sort of writing out your thoughts, at least for me, I didn't really think necessarily about the reaction. But once the book was out and a lot of people read it, and there was a lot of very vocal criticism. So, for example, if you go on Amazon, you can find pages and pages of people who just think I'm essentially, the Antichrist, and I don't know what I'm doing, and I'm a terrible writer. And I've read most of those, and they're really interesting, and a lot of the criticism is valid from their perspective, and some of it isn't. I get a lot of regular hate email and regular snail mail that's hate mail from pain patients who feel that I don't understand their suffering, and I can totally understand. I can appreciate that. So there's been sort of that piece of it, but I've also had a lot of amazingly positive responses, people who've told me this really helped them understand their addiction or their family member's addiction. One of the most gratifying things for me has been just getting emails from other doctors in practice saying, thank you so much for vocalizing what I had been feeling and thinking for decades. And I'm so glad somebody kind of put it down on paper and you got it just right. And that is almost the most rewarding for me, when my peers, that I don't know, all over the country have emailed me and say, thank you, you got it, and thank you for writing Drug Dealer MD. So it's been really mixed, but I would say overall very gratifying, because I feel like I've been able to have some small influence on the national conversation and introduce some ideas that are now widely accepted, but actually when I was writing and when the book first came out, were really controversial, and kind of, very much counterculture and kind of against a prevailing dogma. So it's also interesting to see how that slowly shifts, and then what was the counter narrative is now basically the accepted narrative. And it's just fascinating how that, and to have had the opportunity to be a part of that has been really gratifying. One interesting thing, just internally, psychologically, speaking with a fellow psychiatrist, I've had quite a few people come up to me and say, "Wow, you're really brave." And I can honestly say I never once felt brave. Like, it wasn't like I had this internal, like, I think it was too dumb to know type thing, as well as kind of feeling like this so much needs to be said and is so true that a question of bravery or whatever didn't come into it. But looking back, I can say, well, I guess that was kind of brave. Do you know what I mean? It's funny how at the time I didn't like, oh, should I or shouldn't? It didn't even come into question. It was just like, oh, that we really need to let people know all of the pressures inside medicine on prescribers that have led to this problem. It was almost like a defense of the profession, which is funny because the book is called Drug Dealer MD. So I've had people say, I didn't want to read the book, and the book was so different from the title. I've had people say it's not a good title because really, in a sense, you're rallying to defense of physicians and the healthcare community, talking about why it is that, people, including myself, who went into the profession to do good, ended up, doing evil.
It does. It's a captivating title, and when reading it, the title starts to make more sense.
Yeah.
You sort of see how and the ways in which doctors have, either, intentionally or unintentionally helped contribute to the crisis.
Mm-hmm.
Thank you.
You're welcome. And by the way, Henry Knowles Beecher is definitely one of my heroes in terms of the history of medicine.
Mine too.
Yeah.
Mine too. I've had the distinct privilege of treating patients in the addiction medicine clinic at Stanford. It's been a wonderful opportunity to work with you. What's been particularly encouraging is that many patients intentionally seek care in the clinic because of your expertise in leadership in addiction medicine. How has this reputation and expectation challenged or reinforced your philosophy of practicing and prescribing and treating patients with addictions?
So it's always a little mixed for me when people come to the clinic because they've heard me speak or read my book. I always worry that they come in with expectations that I'm not going to be able to meet. So that's kind of hard. But what I try to do either way is sort of set expectations early on around what we offer, because the truth is that we're a pretty small outpatient ambulatory clinic, and we really rely on our partners in the community and our psychology colleagues to do the heavy lifting. So I like to just kind of like frame it that way when people first come in. And I guess also just in general, the longer I practice medicine, the more I feel like I don't really know what I'm doing. And so I found that the more I learn and the more I see patients, the more humble I've become in the face of sort of the complexity of problems that people deal with.
I've certainly found that to be the case in my 2 or 3 years in practicing as a resident. The more you learn, the more you realize you don't know.
Right, that's right.
Thank you for that wisdom. Lastly, many of our listeners are early career psychiatrists and trainees, many of whom are contemplating a career in addiction medicine. At the very least, as psychiatrists in the community and in other settings, we will treat patients with addictions, often comorbidly with other primary psychiatric disorders. What advice would you give to those listeners, those future psychiatrists and trainees, medical students? What do you wish you had known or paid attention to earlier on in your career? And how can we be on the front end of these trends to help mitigate potential suffering down the line?
Well, I would say contrary to the kind of don't ask, don't tell policy that was encouraged when I went through, I'm seeing more and more young people who are interested in treating patients with addiction, eager to get into advocacy. It's really, your generation is totally different from mine, and it's really hopeful. It's just wonderful to see how many people at your stage of training are interested in this problem and wanting to learn. So that's really awesome. I would recommend considering an addiction medicine fellowship or an addiction psychiatry fellowship. I think it's a great way to take just an extra year and sort of gain expertise and then go out and be a leader in the field. There are so many places that don't have anybody with addiction expertise. And so if you just get a little bit of extra training, you're immediately the expert just by virtue of the fact that there aren't many people with that expertise. And it's really fun to kind of be a person that can answer questions that a lot of other clinicians have and don't know the answer to. So you can really, it's fun to kind of come in and help solve these hard problems. And then I would say more broadly, sort of philosophically, here at Stanford in my training, there was a huge emphasis on data and on science and, collecting data and, using empirical kind of research techniques. And I really want to encourage young people, like if that's what you're into and that's what you're good at, great. But if you're somebody who's more interested in story and more interested in narrative and in like what people say and how they move and stuff that you really can't quantify, don't let anybody tell you that that's not worthwhile. That's so important too. There are just different ways to study it and different ways to document it. And so I really want to urge young people, not to feel like the only way to do science is to, crunch numbers or use statistical analyses or do a randomized controlled trial. There are lots of lenses, both, philosophical lenses, anthropological lenses, sociological lenses, public health lenses, through which to study and examine these problems and really contribute to knowledge. Because I feel like, people kind of say, a lot of young people say, well, I'm kind of interested in doing research, but I don't really want to do, that kind of database or data collection. I'm not going to go into the lab. So I guess research isn't for me. And that's really not true. There are so many, like, look at you, you're a historian. Like, what a great lens, right? So valuable, like these repeating patterns through time, what's the same, what's different. I wish people recognized, young physicians recognized the many opportunities, or they should, if they don't have them, they should push for them. Opportunities to study these problems from many different angles, and the opportunities for scholarly work and publication, because I wish I had had that sooner, somebody encouraging me, because I've never been good really at math. And like analytic, like the scientific method, like that's not how I think. I'm much more scattered and organic and like random. But I am pretty good though at like piecing together disparate ideas in order to like observe themes. And I love patient stories, and I think I'm a good clinician. And I wish I had someone earlier sort of say, hey, that's a valuable skill set. And it's valuable in scholarly work, not just in clinical work, and kind of encourage me. So I really had to discover that myself, really late in the game. So like, just the other day I had a wonderful young person who's in an addiction medicine fellowship, who's doing a study of incarceration related to overdose risk. And, she's like a wonderful writer and thinker, such a talented young person. And she was letting herself kind of get pigeonholed into this project where she was going to have to collect survey data and then analyze it. I was like, why don't you just like find one of these people and get their story and follow them through time? I would be so much more interested in reading that than like survey results. Right. So that's sort of my message, my public service announcement.
Thank you. I do agree. I think there's a place for everyone at the table, and it's nice to hear from a thought leader and an expert in psychiatry and addiction medicine that the role for the humanities, the social sciences, the arts have a place and should have a place at the table.
Yeah.
Dr. Lembke, it's been a true pleasure and honor to sit with you and talk with you about these topics, and thank you so much for the generosity of your time.
Well, thank you. It's been my pleasure. You're a joy to talk to and a joy to work with.
Thank you.